Hello, everyone. Thanks again for tuning in. We're very excited to have all of you on this week's second part teaching on the clinical gap. And today we've got Alexandra, no, sorry, Dr. Vivian, who is going to be presenting the case-based presentation as part of the clinical gap case-based series. So please stay tuned, engage, ask your questions, and I'll pass the mic over to Dr. Vivian, who is going to continue with her presentation. Thank you.
Okay. Hi everyone. Um, Sorry for the delay in starting. It's just a little bit of technical issues. But if you can see my slide, please can anybody see my slide? Hello? Can anyone hear me? Hello? Can anyone hear me or see my slide?
Yeah. Move the slides. I can see you. I can hear you. I think they can hear you as well.
Okay. How do I know if
No, they will. They are hearing you. There's no issue. They've been saying yes
okay.
on the comment.
All right,
So just move the slide so I can confirm for you. But we,
okay. All right. So
yeah. So it's working.
all right. Today's presentation is a case-based review of okay. Okay, so today's presentation is a case-based review of acute kidney injury, and the learning objectives is the definition of acute kidney injury, how would recognize the clinical presentation of acute kidney injury, identifying the causes and the management, and also how to escalate and refer. So this we are going to be discussing it under these headings. So this is a case presentation of a woman, a 55-year-old woman that was referred by her GP to the emergency department. Sorry, sorry, there's a lag I'm hearing and I'm affecting the presentation. Okay, she presented with a 3-week history of worsening shortness of breath, leg swelling, weight gain of 10 kilograms, and she's in the review of systems. There's no chest pain, there's no GI symptoms, no urinary symptoms. And her past medical history, in her past medical history, she has no history of cardiovascular disease, but she has had a positive family history of rheumatoid arthritis in two of her sisters. The exam findings, um, we have she's alert and oriented, though she's dyspneic with a respiratory rate of 24 hypothermia, and her oxygen saturation was 93% of the air. She also has basal crackles. And then the cardiovascular system, she has a heart rate of 90 and is regular. Blood pressure a little low, 105 over 70. And she had an elevated BP, about 6 cm elevated. And then her temperature is normal, no abdominal findings, but she also has bilateral pitting edema up to the knee. So the differential diagnosis, there are quite a number that might present with similar symptoms. It could be cardiac in origin, like for this case, is most likely acute decompensated heart failure or cardiac tamponade because of the elevated JPC, breathlessness. It could also be pulmonary in origin, like acute PE, giving the breathlessness. It could also be renal, which is what we're dealing with today, acute kidney injury, or nephrotic syndrome, or glomerulonephritis. These ones are supported by breathlessness as well as the volume overload. And then could also the same thing supports liver, um, chronic liver disease or endocrine issues like hypothyroidism. Cop- this one is supported by the weight gain. And there are other things that could cause the fluid retention, the medication, if she's on NSAID or steroids, or she's on calcium channel blockers, or some other hypertensives. And again, she's 55 years old. I didn't include this here, but she's 55 years old. She could be on hormonal replacement therapy, which would also cause fluid retention. But amongst all of the differential diagnoses, the most likely diagnosis is most likely either acute decompensated heart failure or acute kidney injury. And the reason for this is the rapid fluid retention over 3 weeks, the systemic symptoms of breathlessness, and then there could be possible intrinsic causes like if she was on any of those medications or any problem with either her kidney or heart. So these are the two most likely symptoms given her presentation. If she was to present in A&E and we don't have any investigation results. So the management would follow the ABCDE approach if this was an ED presentation. So the ABCDE approach, she's breathless, so we give her oxygen and then would do some investigation while waiting for the results to come out. We would monitor her fluid. She has fluid over she obviously has fluid over the breathlessness and the pitting pedal edema. So we would likely this patient would likely monitor her strict fluid input and output with a fluid restriction. Then if I want to give her IV diuretics because of the pitting pedal edema and her breathlessness, then we'll look for the underlying causes from the investigation results. Here are the investigations. I've classified the investigations into blood, urine, and then imaging. For the bloods, would do the urea creatinine electrolyte full blood count. In this lady, full blood counts, the full blood count came out with hemoglobin of 11.4, white blood cell count a little bit elevated, platelets elevated to 220. There is hyponatremia from the investigation that we were giving, and hyperkalemia 6.4, and also the bicarbonates a bit low, and there is acid from the venous blood gases that was done. There is obviously metabolic acidosis. Other investigations that might be done will be C-reactive protein autoimmune screen, and also because we are considering it might be heart failure, we also want to include pro-BNP. In this patient, urinalysis is very important because we might want to be looking for things like urinalysis and urine microscopy, because we might want to be looking for things like because we might want to be looking for things like proteinuria in the urine, protein in the urine, and also the red cell cast. Then the imaging includes would include the chest X-ray. In the case, we were given chest X-ray findings of bilateral pleural effusion and congested lung fields. And because we are also suspecting heart failure, we might want to be doing ECG and echo, and then renal ultrasound because the second differential is AKI. So ideally, with the investigation findings in this patient, it's tilting more towards AKI because of the serum creatinine ratio, which I'll talk about much later. Serum creatinine ratio and the hyponatremia, hyperkalemia, and metabolic acidosis. So for this patient, she'll be managed in the high dependency unit or intensive treatment unit. I would also send a referral to nephrology. Now, for the main case, so the definitive diagnosis for this patient is acute kidney disease, acute kidney injury, and these are the reasons for the diagnosis. So, for this patient had a raised had her creatinine was 220, and her initial creatinine, I forgot to include that her initial creatinine was 80 80. That was the last one she did. So according to the criteria, if she has had a raised creatinine of more than 1.5 or times the baseline being 80 in this woman within 7 days, or reduced urine output, that would be a definitive diagnosis for acute kidney injury, in addition to the symptoms she presented with, and then the combination of hyponatremia, hyperkalemia, and metabolic acidosis. So then the definition here, acute kidney injury is a clinical syndrome. It's characterized by the rapid reduction in renal excretory function, glomerular filtration rate over hours to weeks. This lady, she had it over 3 weeks, leading to the impaired control of extracellular volume, the electrolytes, and acid-base balance. So she already has the whole picture. According to K, there's a KDIGO class criteria definition criteria for acute kidney injury. In this criteria, it uses serum creatinine or urine output. So is listed here. The serum creatinine has to either be greater than or equal to 26.5 micromole per liter within 48 hours, or 1.5 greater than or equal to 1.5 times the baseline. So the last creatinine that was done, the new one has to be greater than or equal to 1.5 times that baseline, and is presumed to have occurred within 7 days prior to presentation. For the urine volume, it has to be less than zero point 0.5 mils, sorry, less than zero point 0.5 mils per kg per hour for over 6 hours. So that's like oliguria. No. Okay, so for the epidemiology, this acute kidney injury is clinically significant because it constitutes about 5% of acute hospital admissions and about 30% of intensive treatment unit admissions, as well as about 50% mortality, which is quite high. So for us to so AKI can quickly progress. So to determine the severity will tell us what the treatment should be like. So to determine the severity, the KDIGO staging system is still used. Still similar to what I have said earlier, is based on Hello. Can anyone hear me?
Yeah, I can hear you.
Okay, so I'm back again. Huh. Is anyone still around, or do I have to reschedule?
No, no, I think just carry on. They know that you're back.
Okay, let me go back to the link. Okay, okay. Sorry, everyone. It just keeps going on and off. Yeah, that's gone off again. All right.
Oh, do you want to reschedule?
I don't know. I feel like it's very disjointed.
Okay, we can. Okay, fine. If you would like to reschedule, then we can do that.
Yeah, I think I would prefer to reschedule.
Okay, all right, guys. Thanks for tuning in. Due to technical difficulties, I mean, my sincere apologies. Due to technical difficulties, would need to reschedule this. When do you want to take the next slot? Hello. Okay, I think she's gone. So we would have to reschedule this due to technical difficulties. Thanks to everyone that's come for the presentation.
No,
And
I'm still here.
yeah, so I was saying, are you going to take the next slot
Okay, when is the next slot?
next Wednesday?
Okay, yes, I'm happy to take next Wednesday.
Okay, fine. Thanks, everyone. Thanks for coming. See you next Wednesday. Bye now.
Mm. All right.